Okay, now it's recording. Very good.
Hello all. I am Dr. Marty Dayton. You are in the weekly AASCP Wednesday night Zoom webinar. Our speaker today is Stefan Hartman, MPAS, PAC. His presentation is titled Muscle-Centric Medicine, Principles of Exercise Science. Stefan had a holistic upbringing and has never taken an antibiotic. He excelled in tennis and physical fitness training and instructions. And he also excelled in cerebral training, graduating magna cum laude from the University of Central Florida. Stefan, the mic is yours.
Excellent. Thanks for having me, Dr. Dayton and American Stem Cell Physicians. I'm going to share my screen here and we'll get going with this presentation on one of my favorite topics, which is the muscle-centric medicine approach. So in this lecture, you're going to learn about the mechanism of action of the muscle to reverse the metabolic syndrome and to prevent most of the common diseases we deal with on a daily basis in primary care and also specialty practices. But we're going to give you guys realistic modalities that you can implement for your patients and for patients to implement tomorrow. Setting goals, tracking progress, building a program, the consistency, nutrition. We're going to go through the different types of muscle fibers and the different type of exercises out there that you can implement into your program to see which fits best. So, looks like some of my pictures here got in the way. Oh, here we go. So benefits of improving muscle include reversing autoimmune diseases. Dr. Terry Walls has spoken about this multiple times. When you listen to her stories at A4M, she reversed her multiple sclerosis this way through mostly, Paleolithic diet and resistance training. Improving your muscle mass will improve your resistance to cold and viral and bacterial illnesses, right? COVID, for example, one of our best weapons against COVID illness is muscle. It lowers your blood pressure, it increases your HDL and lowers triglycerides, it improves insulin sensitivity, thus lowering diabetes risk, reverses non-alcoholic fatty liver disease, which is on its way to being the #1 reason for liver transplantation by 2030. It improves bone strength and reduces fracture risk in the elderly. It improves muscle tone and reduces the risk of falls and hip fractures in the elderly. We all know that a hip fracture in the elderly is associated with a premature death in 50% of these fracture individuals in 4 to 5 years. Decreases visceral fat, which is highly inflammatory fat found on the organs like your liver. And increased muscle mass lowers risk of all-cause mortality, including decreased cancer death by 13%. So that's striking in and of itself, is that muscle can lower the risk of cancer. So let's talk a little bit about the mechanisms of action for you doctors in the chat, why you would want to care about this at all. So skeletal muscle is the major and primary site for glucose uptake, especially after meals. With increased muscle mass, there are more DORs, glucose transporters, available to bring glucose into the muscle cells. This leads to greater capacity for glucose disposal from the bloodstream. And we all know this can help decrease and prevent the diabetes. GLUT4 translocation. Resistance training stimulates the movement of a specific glucose transporter called GLUT4 from storage sites within the muscle cell to the cell surface. This increases the number of transporters available to import glucose, further enhancing glucose uptake. And this is a picture of my outdoor gym behind my office. Muscle is an endocrine organ. I explain this to patients every day in practice. The old school thought is it's just a lever. It's for bodybuilders just to grow muscle, just to look good on stage. And this is false. It is an endocrine organ. It's an immune organ. It's huge. It's all over your body. There's convincing evidence that factors secreted by skeletal muscle act as endocrine signaling mediators and are involved in the beneficial effects of exercise on almost all cell types and organs. So it modulates all these inflammatory markers. We discuss in these meetings like CDPM with Dr. Halassa and Clearfield's group, and this group here, how to mediate these inflammatory markers like IL-7, TGF-beta, IGF-1, IL-6. We talk about the methylene blue, we talk about clotho, we talk about all these esoteric things. But we have readily available muscle that we just have to grow and stimulate, and it can control our inflammatory and cytokine release if we just build our muscle a little bit better. Improved insulin signaling. So insulin receptor activation. Resistance training can enhance the sensitivity of insulin receptors on the muscle cells. This means that even lower levels of insulin can effectively bind to these receptors, triggering the necessary signaling pathways for glucose uptake. So in practical terms, this means that the patient who is insulin-dependent diabetic would need lower doses of insulin, right? And this could potentially save their life because we know that increasing the dosage of insulin and increasing diabetic medications is an increased risk for death and adverse side effects. So if we can use a lower dose of a medication and have a similar effect, we want to always do that, right? Lower dose possible for an effect. The way you do this is you tell the patient they need to grow their muscle. You explain this to them, right? Improved signal transduction. Resistance training may also influence the cascade of events that occur after insulin binds to its receptor. This can lead to more efficient activation of enzymes involved in glucose storage within the muscle cells as glycogen. We're going to get to that a little bit more later. Let's talk about mice. We all talk about mice studies in these groups here. So cancer, breast cell exposed to serum collected after a single bout of acute exercise and thereafter injected into mice led to a reduction of tumor formation. So when you see that exercise here in a mouse model, right, can decrease tumor formation. Pretty cool. More on the muscle-centric medicine, metabolic adaptations, increased glycolytic capacity. Resistance training enhances the muscle's ability to break down glucose for energy production through a process called glycolysis or glycolysis. This provides an additional pathway for utilizing glucose, further aiding in blood glucose control. And improved mitochondrial function. Mitochondria are the powerhouses of the cell, and resistance training can increase their number and function within muscle fibers. This improves the muscle's ability to use both glucose and fatty acids for energy, contributing to better overall metabolic health. Gluconeogenesis is the process by which the liver produces glucose from non-carbohydrate sources like amino acids. Resistance training can potentially suppress gluconeogenesis, preventing the liver from producing excess glucose when dietary intake is sufficient. So overall, the combination of these effects from increased muscle mass and resistance training leads to a more efficient system for managing blood sugar levels. With more capacity for glucose uptake and storage in the muscles, improved insulin sensitivity, and the potentially reduced production of glucose by the liver, the body becomes better equipped to handle carbohydrates and maintain healthy blood sugar control. So I explain this to patients is that you want to have a donut sometimes and not have your blood sugar spike for 9-12 hours of the day. If you want to have that donut, you need to train. You need to make your muscle as dense and as big as possible. You need to make yourself a carbohydrate and glucose burning machine. Then you can tolerate a donut. But if you are low muscle mass and you are not training, you do not know how to process that donut. And thus, if you wear a CGM, what you'll see is that you will have high blood sugars after eating that donut for 8-12 hours a day. And what this leads to, we see this in the lab work every day, high A1Cs, high fasting blood sugars. Big problem leads to diabetic neuropathy, diabetic retinopathy, ocular disease, Alzheimer's, dementia. This high glucose floating around in the bloodstream for hours is highly inflammatory and leads to pretty much all diseases that we talk about here in these lectures: diabetes, cancer, heart disease, neuropathy, chronic pain, inflammation, what we deal with every day in practice. And the biggest lever we have against this is muscle, because the patients, they're going to eat a donut on occasion. It can't be the end of the world. The way you can process, carbohydrates correctly and be more carbohydrate tolerant is to grow your muscle system and grow it as sturdy as possible. So how are we going to do this? Well, we're going to set some goals, right? What is your goal? Is your goal weight loss? Is your goal overall health? Reducing your risk of death, right? This all can be achieved through strength training. Are you just trying to rehab from general deconditioning, frailty, sarcopenia? You'd be surprised how many patients can't even get off the ground, right? They struggle getting off the ground. Are you trying to reverse the metabolic syndrome? Are you trying to improve your resistance to diseases? These are all possible through resistance training. We should start out with some baseline markers of their health. This will help improve the patient's willingness to stay with the program. So maybe you get some baseline labs, you get them a CGM, or you get here a DEXA body composition. This is kind of a cool scan that takes a look at their fat and their muscle and their bone, not just the bone. The typical DEXA scan that we order every day in primary care just looks at the bone. No, we want a DEXA body composition analysis, which looks at the percentage of their fat to muscle. Very cool test. You want to look at their blood pressure, maybe their scale, look at the scale. Although I tell patients, the scale may not always move in the direction you think it might move, right? Because, fat weighs more than muscle. And we'll talk a little bit about that later. BMI measurements, I'm not a huge one to do those. I don't do those in practice. I think they give a false sense of health. You really want to monitor visceral fat, and the best way to look at that, you can ultrasound, you can see a fatty liver, an abdominal MRI, a DEXA body composition scan, body impedance testing. Also look at the LFTs. If their LFTs are elevated above 20, that's kind of a hint towards liver fat or inflammation of the liver. But don't focus on the BMI so much. Visceral fat is a independent predictor of all-cause mortality in men. So we really want to focus on the fat on the abdomen primarily. Let's take a look at kind of a basic program you might do for someone. This is a 56-year-old African-American female that I worked with a long time ago. She was 315 pounds, osteoarthritic knees. She couldn't squat or deadlift. She had days where she had a rough time and couldn't even get to the gym because her knees were so painful. So you can see we built her a program here. A dumbbell lawnmower rows, cable fly, lat pull down, seated machine, chest press, rear deltoid machines. We use a lot of machines for her just because that was safer for her. And she wrote down the sets. We did a classic bodybuilding program. We would do 1, 2, 3, 4 sets at about 10 reps each. And then she would also describe how she felt on these, right? Did it hurt? Is something ache, pain? And we would adjust that the next time we trained. So keeping track of their progress is sometimes helpful and helps them as a tool to stay consistent. And again, going back to consistency, the patient has to be aware that self-sabotaging tactics, drinking calories, is going to offset anything that they could do in the gym. So if they're drinking their calories, sodas, beers, hard ciders, doesn't matter what it is, they're drinking their calories. This is going to impede their ability to recover. It's going to deplete their glutathione levels. It's going to saturate them with calories that they don't need. So they have to be aware of some of these basic things here. That could bring me to nutrition and calorie in, calorie out. I'm not a huge fan of counting calories for weight loss. I prefer the patients just focus on the nutrient density of the diet, focusing on an ancestral diet, which I've talked to some groups about here in the past, focusing on nutrient density. So eating the grass-fed beef, steak, elk, deer, incorporating some level of organ meats. This will provide that satiety to the stomach, to the brain, to inhibit that feedback to keep eating. I think a lot of obesity we see in America is because of nutrient deficiencies. So that brain, it goes and it keeps seeking that food, that calorie, thinking that eventually we'll get that nutrient that those mitochondria, that those cells are craving for. So this drives a lot of overeating habits, is because we have plenty of calories, but not enough nutrients. But you can count calories as well. That can help in addition. You sure can overeat on an ancestral diet. I've seen that happen. Some people drinking way too much raw milk and eating way too much, fatty beefs, and they don't lose any weight. So you can monitor your caloric intake. That helps as well, as long as focusing on the nutrient density in addition. And there's lots of calculators you can have patients do this. Some cheap, free online calculators to track how many calories you need per day. This is what I alluded to earlier. Again, not focusing on the scale. The scale won't move always because, well, muscle is denser, but it weighs about the same as fat, but fat takes up more room. So what we're going to see in the patient is that they're going to lose fat. They're going to start shrinking their fat cells. Their clothing may not fit as well, but they may not change the scale too much because they're growing muscle at the same time and it's replacing the fat mass. So tell them not to worry about the scale too much. I wouldn't even focus on weighing them all the time because that might lose heart. It doesn't matter so much. If you're getting stronger in the gym, that's most important. Let's talk about type 1 and type 2 muscle fibers. So the fast twitch muscle fibers, this is what you see in your athletes, Usain Bolt, Olympic sprinters. They look great because they're highly muscular guys. These are the bodybuilders. These are your pro football players. And then look at your marathon runners or, these long endurance runners, right? They have smaller muscle sizes, right? So they have more slow twitch muscle fibers. They're type 1. So you can focus on growing these with endurance type of training. The fast twitch fibers, this will grow with the interval training, the sprinting, and the resistance training, the lifting of the weights. So again, why the muscle-centric medicine approach? We're going to summarize this here: improving the glucose tolerance, improving insulin sensitivity, and preventing basic diseases of frailty of age, right? Preventing fall risk of age, and then modifying the immune system, modifying our inflammatory response, modifying our response to illnesses, COVID. The whole pandemic, it wasn't COVID that kills people. It was people's own immunological response to the bioweapon that killed people. It was people's release of their cytokines. The cytokine storm is what killed people. And you typically didn't see this in someone who was lean, fit, muscular. Sure, it happened, but maybe their diet wasn't the best. Predominantly, it helped people. It affected people who had the sarcopenia, the large predominant fat mass. They had high inflammatory cytokine release. Let's talk a little bit about hormones in relation to the resistance training program, because that's what we talk about in these societies like the Clearfield group and here. Growth hormone testosterone increases in younger men and women with heavy resistance training. Elderly women and older men had no response to heavy resistance training. So I typically will, and personal trainers know that I'm very good about this, I replace hormones in patients who are older. It's because they won't have the same response to resistance training as a younger individual would be. So you get them on hormone replacement and they will have much better recovery and much better response to the resistance training and see much quicker improvement in their body composition. So something to keep in mind is that the hormone replacement goes hand in hand in the older population with resistance training. Resistance training builds your brain. So this is very important because Alzheimer's is on its way to become one of the leading causes of morbidity and mortality in this country. Resistance training is probably our one and singular lever against Alzheimer's disease. The first adaptation that happens in any resistance training program in the untrained individual is that white matter changes in the brain. You'll actually get smarter. You'll grow more white matter. If you look at MRIs with the people who are training, their MRIs will change with more white matter. And that's because they will grow new neural connections to their muscle. So when I train a new person in the gym, you get them on the bench press or the rings and their arms are like this. They're pushing like this. They can't control it. And that's because their brain has not made these neural connections to their muscle. So the first adaptation isn't they're going to grow more muscle or lose fat. Their brain's going to grow new nerve signals to their muscles. So over time, this shaking of the arms when they're pushing weight, it stabilizes. And then it's a smoother motion. I see this all the time because since my gym is in my backyard of my office, part of my physical exam is like bringing them out back and seeing how they perform in the gym. Everybody shakes. No one has the brain connection to the muscle. Let's talk about a few case studies of patients who sent me their progress reports for American Stem Cell Physician lecture tonight. So this is one of my patients. She started out decently overweight, but beside that, she had a lot of physical ailments and mood issues. Here's her on the right. She's doing a lot better now. She's working with a trainer here, Diego, and she's made a lot of progress. So she initially was 256 pounds. She had poor functional movement. She had exercise-induced asthma, edema in the legs, no muscle definition, poor recovery from old hamstring, low energy, poor sleep, hot flashes, low libido, chronic inflammation, and brain fog. Now she's 204 pounds. She's lost 52 pounds. She's 75% improved functional movement. She no longer experiences exercise-induced asthma, 50% reduced edema in the legs, 50% improved muscle definition, improved recovery from old hamstring tear, 90% improved energy, 90% improved sleeping, 0 hot flashes, 80% improved libido, and 50% improved chronic inflammation, and no brain fog. Now, how did we do this? Well, we fixed her diet. We got her on a resistance training program with a trainer, and we did hormone replacement therapy and nutritional therapies. The diet is keto, gluten-free. She trains multiple times a week. She goes to my gym. She does cold forge, sauna. She does mobility training. She does chiropractic. Key observations, she noted that testing for appropriate supplementation and hormone treatment was critical in increasing overall energy and well-being to motivate continued exercise, diet, and weight loss. And that's key there, right? You're going to lose motivation if you don't feel well. So that's why trainers, they're going to be your friends to patient referrals, right? They're going to refer you patients because their clients in the gym are going to be happier because you're getting them on the right hormones, the right nutrients so that they can recover and they're not aching and complaining. So they're going to have motivation to go to the trainer and the trainer's going to get them fitter. You're going to be happier because the patient's getting more mobility, is getting out of pain, is getting stronger, less fractures, less disease, less illness. They're not calling you because they're sick all the time. And the trainer's happier because they're recovering and they're training hard. So I recommend patients always hire a trainer. It's sometimes very difficult to go from zero to, training without someone helping you. This is another patient, ex college football player here. He was a bit overweight. He was trying to eat well. He was trying to hit the gym. He'd been doing this for a time, but not much was changing there. The biggest change for him was getting on testosterone. He had some injuries and his testosterone was super low. So we got him on testosterone, and then he finally started making those changes in the gym, and you can just see the body composition change on him. This is an interesting case here. This is a 52-year-old male. And so he's gone full into this, right? He's gone into like bodybuilding. And I don't know if I'm too happy about this, but it's fun to see what happened here. So he started out here on 4/25/2023. He got a DEXA body composition scan. And he had a 22% fat there. So he was okay with that. And then he followed the iron DPC protocol. He lost weight. He did the supplements. He did the training, and he got down to 14.9% body fat. And then he got down to 12.7% body fat. But then he went on a bulking phase, right? Because he got a coach, and the coach was like, oh, if you want to gain muscle, you got to eat more. So he started eating more calories, and now he's back up to 21.8% body fat. But that was intentional, right? He's trying to gain mass and muscle, and we'll see how much muscle he gained as well. He gained a lot of muscle through this program as well. So his lean mass, it went from, what was it? Lean mass was 139 back in 2023. He's now at 158.9. He's gained a decent amount of lean mass. His body fat is, of course, higher now. He's gained 22 pounds of fat, from where he was previously. His labs are in accordance. They look like this too. But we'll see he's going to go on a cut soon. And that's a classic bodybuilder thing to do, is they will go on cuts and bulks. The bulks are intending to make them gain more muscle, but as a side effect with eating more calories, they gain more fat as well. So they go and gain both strength, more muscle, and more fat. And the goal is to lose the fat afterwards, but I don't know. I'm not a huge fan of it because, fat is kind of forever, right? You can shrink the fat cells, but you can't get rid of them. This is another patient, Francesca here, 48 years old. She was beginning weight, 250 pounds. She had no real knowledge in exercise or strength training. She followed a standard American diet. She had, the typical things you would see in primary care: anxiety, depression, chronic pain, acid reflux, inflammation, high insulin, glucose, irregular cycles, painful cycles. We see this every day in primary care. The conventional approach is lacking, let's just say. We diagnosed her with insulin resistance, pre-diabetic, estrogen dominant, low thyroid function, and hormonal imbalances. She's now 3 months into training with me at my gym. 219 pounds. She trains 5-6 days a week. She does low carb keto. Her anxiety is well controlled without medications. We put a CGM on her, and we're going to show you those results in a little bit. We put her on some supplements and medications for hormone balance. She now has lower fasting glucose, increased glucose tolerance, no acid reflux, joint and body pain is gone, cycles are regulated or unremarkable, and the inflammation is minimal, if any. Here is some of these interesting glucose findings. So you can see here on the right, she started a little bit higher average blood sugar readings, and it's just gone steadily down over the past 3 months, right? Just kind of like a slow slope down as she improves her glucose tolerance. We talked a little bit about those metabolic adaptations that will happen earlier, but it's motivating to see it in real time with the CGM, which are very cheap devices that I recommend everyone prescribe for patients with the metabolic dysfunction when starting a program, because you can just see how it improves. Why is this happening? Well, think about it this way. If you have large fat mass and low muscle mass, you don't have the storage capacity for glucose and glycogen. So this picture here is a very cool one. Small glycogen storage capacity, rarely depleted. This is most of your population. You see them at Walmart, Target. They're sometimes on a scooter. They have low capacity for exercise. So they have low storage capacity of glycogen, of sugars, right? Rarely depleted. When you start training, what happens is you have large glucose or glycogen storage capacity, and it's often depleted because you're training all the time. So you can tolerate carbohydrates. You should eat carbohydrates after a workout because you want to replenish your muscle glycogen. So this is the big difference between the highly trained athlete and the general population that does not train. Further observation she noticed, increased glucose tolerance as skeletal muscle increases. Obviously, she's not eating donuts, but she can tolerate carbohydrates a little bit better. Fasting glucose is steadily improving, increasing energy along with strength. The weight loss has been slow, right? But again, we don't care about that too much. The body composition is changing. She's noticed her clothing is dropping. She's having to get a whole new wardrobe because clothing isn't fitting anymore because she's losing size. Body composition is changing on the waist. And she continues with improvement in pain and anxiety and stress. She shows in pictures here the difference of her face. She's noticed this quite striking is the inflammation reduction that she noticed in the face. Typically, this corresponds with reduction in the visceral fat as well. There's a radiologist named Dr. Sean O'Mara on Instagram, and he has shown this quite correlated is with abdominal MRI analysis. You can see that the facial structure, it changes in response to a reduction of the visceral fat. So the patient with the visceral fat will have the round face, the inflammation, the swelling of the cheeks. Sometimes they'll have a bigger nose. This is a sign of the visceral fat. As the visceral fat goes away with training, the face starts to shrink, the inflammation starts to go away. Let's talk about a different sort of exercises you can incorporate yourselves or you can advise for your patients. So we can talk about the compound exercises. So compound exercises is anything that puts stress on the whole frame. So this can be a bench press, this can be a deadlift, or this can be, as I like to do, is Olympic rings. Olympic rings put stress on the entire frame, abdominal muscles, as well as the deltoids, the triceps, and of course the chest muscles. You go down slowly, you get a huge stretch, and you push all the way through midline. You're putting a whole stress on the entire central nervous system. It's a fantastic workout, huge bang for your buck. I don't recommend doing any sort of sit-ups. And I was working once with this physician in the ER. I was his scribe, and he was in such bad back pain. I was like, what did you do? He's like, well, I did like 100 sit-ups because I want to have abdominal muscles like you. I'm like, I don't do any sit-ups, okay? I'm not doing this yanking on my head. You're just going to give yourself a back injury or a neck injury that way. You do compound exercises, you activate your core, you make that mind-muscle connection with your core. I don't do really much for core exercises. I just make that mind-muscle connection. All right, let's move on here. Accessory exercises, these typically are done by bodybuilders at the end of a workout. So they're working smaller muscle groups, maybe the tiny deltoid here, maybe isolating the trapezius muscle or the rear deltoids, as he's demonstrating here. Machine exercises for the most part. Again, calisthenics, these are very simple. You can do everything. Here's an example of an abdominal exercise. I guess I will do some level of abdominal exercises on occasion, but not primarily. Dips, ring dips, pull-ups. Again, you can use bands assisted pull-ups if you can't do a pull-up, to train yourself. We do that commonly at my gym. You can do bicep curls. You can do tricep extensions. You can do squats on the rings. You can do the knees over toes lunges to open up those hip flexors that are so tight on people. You can do pistol squats, rows, anything of this nature. It's a very versatile equipment. And again, it's making that mind-muscle connection. Powerlifting and Olympic lifting and strength training. So this is where you go and you lift super heavy weights for 1 rep. The 3 big lifts is the deadlift, the bench, and the squat. These are done in powerlifting competitions to see who's strongest. And they are great for building strength. Strength rep ranges typically include 3 to 5 reps at 5 to 7 sets. Longer rest intervals compared to other modalities. So you will do maybe 2 to 3 minutes between heavier lifts, heavier weights. This helps the muscle grow stronger. This is well used by strength athletes and well known. Also in the literature and exercise science is you do heavier loads for shorter amounts of reps and sets to increase your strength. This way, I have used it to go back to my regular bodybuilding style training where I'll do higher rep ranges with a heavier weight to overload the muscle, right? We're trying to progressively overload. That's why it's called progressive resistance training. But typically, I don't recommend powerlifting for patients. It's because I've rarely seen people do these appropriately. Few people have the ankle and hip mobility to perform a deadlift or a squat correctly. There's other ways to do these rather than just try to go and do it. It's more risk than reward, in my opinion. And back surgeons will tell you the same. Bodybuilding, again, we're doing here between 8 and 12 reps or higher rep ranges, or we're doing drop sets. We're trying to increase the overall volume. And that's what the research demonstrates. It's the amount of volume you do throughout the week that will cause the muscle to grow and stimulate it to grow. So the old theory that I learned back in my exercise science program was 10 to 15 reps, 3 to 4 sets. But you can still grow muscle at much higher rep ranges, 20 plus reps. It's just about stimulating that muscle overall volume. So classic bodybuilding equipment in gym, cables, very common. You'll find these in every gym. You find them on the pull down here. Dumbbells. I actually love dumbbells. I want to get some for my gym. There's nothing like sitting under some heavy dumbbells and getting that huge pull in the chest muscle and squeezing it together. I've utilized these predominantly. This is an example of a seated row. I like that one because it isolates the back a lot. It doesn't put a lot of stress on the lower back. Now, what else do we have here? Here's a machine press. You'll see these pretty commonly at most gyms. And this is an interesting machine that actually subtracts your weight. It allows you to do pull-ups, whereas I'm demonstrating a one-arm pull-up here. It subtracts your weight through this machine so that you can progressively overload and eventually maybe do a pull-up one day. Cool. I have 3 of these at my gym because I'm such a believer in this system. This is known as the OsteoStrong system, designed for astronauts to use in space. It's variable resistance training. It's a foolproof way of increasing time under tension. And it's great because I have patients that can't do barbells or dumbbells because it hurts their joints. And they'll get on this contraption here, and the resistance bands are such low impact on their joints, they can do it. And you finally get someone who's never trained or hasn't trained in years to train again because it doesn't hurt their joints. So basically, it's these bands. There's all sorts of resistance levels. There's white bands, which actually the white band, even though it's the weakest one, it's sometimes too much for some people. So We got some even weaker ones than that. We found them on Amazon. But basically, again, you're contracting, you're firing all the muscles. You're trying to make that mind muscle connection. This base plate attachment, it allows you to attach the band to that. You can do, bicep curls, pushes. You can do rows. I love the rows on this thing. The constant tension that the bands achieve causes an additional muscle stimulus. Where with other exercises, you'll rest at some points. That resting, that's cheating. You always want the muscle to be under tension, and all good bodybuilders and strength coaches know this. Let's see what else. CrossFit. I don't typically recommend CrossFit because it just leads to too many injuries. People, they're competitive by nature, and if you're in a group setting, you want to compete with other people, and you end up doing something that you shouldn't be doing. But it is good interval training. I give it that. So let's back to a little bit more of the mechanism. What energy sources can the body use? Well, your liver can produce energy. You have a lot of fat tissue that will produce energy, and your muscle glycogen, it stores a little bit of energy. So the breakdown of carbohydrates, glucose, and glycogen involves both anaerobic and aerobic biochemistry. Energy is contained within the molecular bonds of glucose and is released during their breakdown in a process called glycolysis. Glycogen is the storage form of glucose and is broken down as glycogenolysis. So this is something very important to tell your patients, is that your muscle is the storage form for your carbohydrates. If you want to eat carbs, you got to grow your muscle. This is the way to avoid the metabolic syndrome. If you don't have muscle, you don't have a way to store your energy. And where does it go? Maybe it stores it on the liver in the form of fatty liver disease, or it stores it on your subcutaneous or visceral fat. Big problems. So let's talk about, again, the storage form here. This is my CGM. So when I play tennis, I actually will spike my glucose. And this is my muscle releasing glucose. Again, glycolysis, muscle stores the glucose in the form of glycogen. When I play tennis at high level, right, highly active interval training, I release glucose. So this is why my blood sugar will spike to 130 when I'm playing tennis. This is as much as it'll spike when I say, I eat some bread or something. If I eat some ice cream, it might go to like 120. But if I play tennis, my blood sugar goes higher than if I eat ice cream. So kind of interesting, and it shows you that I'm very metabolically fit, and I can tolerate carbohydrate and sugar relatively well because it goes down after I eat. Let's demonstrate another one. This is the hypoglycemia I experienced post-tennis match. So after a tennis match, my blood sugar will drop to about 73. And this happened consistently every time. It would go very high during the tennis match, releasing that glucose. And then when it's done, boom, drops right off. And that's pretty typical of what I noticed when I played at these high-level events. So let's talk about the aerobic metabolism and carbs versus high-fat diets for fuel. So aerobic metabolism is a bit different than tennis. So tennis is both an aerobic and anaerobic sport. So anaerobic uses glycolysis. It breaks down glycogen in the storage form of muscle and releases it in the form of glucose so that you don't pass out on the tennis court. Aerobic metabolism is a little bit different. This is the lower level training where 60% of your VO2 max. So this is maybe under 110 beats per minute. This is known as zone 2 training. You may have heard Peter Attia talk about that. This is where you're training, you're running, you're jogging, you're not out of breath. You can still talk with someone as you're jogging. If you do this for a period of time, maybe 30 plus minutes, you may start to burn fat. For me, I'm a very efficient fat burner. I did some BMR testing. I have like 99% metabolic efficiency in burning fat. So, I think if I start running like 10 minutes, I start burning fat, which is very efficient at this, at lower interval trainings, right? But for an endurance athlete, it may be more smart to eat more fat than carbohydrate rather than glycogen load. For the anaerobic athlete, the athlete like I am, I actually eat carbohydrates because I need it to store in my muscle so that I can release it during a tennis match. I don't think I really ever get into much fat burning in a tennis match. I probably do, maybe in the longer matches, but As demonstrated by my CGM, I'm releasing glucose for the most of my matches. In fact, type 1 diabetics on insulin therapy who consume carbohydrates are at significant risk of developing obesity, heart failure, and retinopathy in such standard practices. The rise in overweight and obesity in type 1 diabetes may be related to intensive insulin therapy coupled with a positive energy balance. Insulin is an anabolic hormone that stimulates lipogenesis and slows basal metabolism, thereby resulting in increased fat accumulation. So I think we do a great disservice to our patients who are type 1 diabetics in telling them to consume carbohydrates so that they can take their insulin. What I think should be better practice in endocrinology is that you put patients on a ketogenic or low carbohydrate diet so that they require less insulin usage. Maybe they'll still need some insulin, right? Because they're type 1, they don't produce insulin. But if you keep them in ketosis, they will require much less insulin, right? So we can use the principles of aerobic metabolism and higher fat and ketogenic diets for the patients who maybe aren't training at that high level where they require carbohydrates. I think there's a very small percentage of the population that require carbohydrates for intense physical activity. But for the most part, you can get away with lower carbohydrate diets. But it's not myself. I need it because I do these high intense activities and I'd pass out otherwise. Carbohydrate oxidation, particularly from muscle glycogen, dominates at higher exercise intensities, whereas fat oxidation is more important at lower intensities. Maximal rates of fat oxidation occur at 60 to 65% of VO2 max. So again, the high intensity interval training that I participate in requires glucose, muscle glycogen, right? When you do lower level training, when you do a little jog, a walk, you don't require that much carbohydrate and you're going to burn more fat when you train at this level. So a walk, a bike, longer duration is probably the best for fat burning. I also like the interval training. Again, you want to train your body to process carbohydrate correctly. So maybe a balance between the two would be the best modality for training. But if you're under time constraints as well, I think the best bang for your buck would be an interval training. So if you have a patient, they don't have a lot of time, get them 6-7 minutes on the bike. Brilliant, right? In and out, done. You're going to get a great bang for your buck there. If you have more time, if you can incorporate maybe a lower jog or a walk in addition to that, fantastic. Do that too. Ideally, both. I train both. So cardio, continuous moderate exercise versus HIIT. So with the exception of marathon or extreme endurance running, which has shown some deleterious effects, there is some deleterious effects. Cardio is beneficial for health and weight management, of course. So again, here's some highlights of HIIT training. Insulin sensitivity, 17 studies measured insulin sensitivity showed significant improvement in response to the high intensity interval training. And again, this can be interval training on the bike, this can be sprinting, this can be rowing, this can be a quick swim, this can be jump rope, this can be kettlebell swings. Heck, this can be even resistance training at the gym. If you do supersets, if you do a chest and back, and then you do kettlebells and you're doing legs, this is interval training for someone who's deconditioned. Fasting glucose, a minimum duration of 12 weeks was necessary to demonstrate improvement in fasting glucose in 4 of the 7 studies, right? So it takes time. Increase in HDL, a minimum duration of 8 weeks of high intensity training was necessary to demonstrate improvement in HDL-C in 3 of 10 studies. Decrease in high blood pressure. At least 12 weeks of high intensity training was required for reduction in blood pressure to emerge in 5 studies of participants not already being treated for hypertension. Decreased weight, a minimum duration of 12 weeks was necessary to see consistent improvement in the 6 studies that examined anthropometric measurement of obesity in overweight and obese individuals. High intensity training versus continuous moderate training. Again, so this is like a jump rope versus a jog. In the 13 studies with a matched exercise volume group in the continuous moderate exercise training group, improvement in aerobic fitness in response to HIIT was equal to 5 studies or greater in 8 studies compared to continuous moderate exercise. Safety, additionally, HIIT has been shown to be safe and effective in patients with a range of cardiac and metabolic dysfunction. So HIIT appears to be promote superior improvements in aerobic fitness and similar improvements in some cardiometabolic risk factors in comparison to continuous moderate exercise when performed by healthy subjects or clinical patients for at least 8 to 12 weeks. So that's always another important thing to note to patients. It's going to take some time, at least 3 weeks. No, not 3 weeks, 3 months to see some real adaptations in anything. So again, examples of HIIT can be tennis, specifically singles tennis, not doubles tennis, not pickleball. I hate pickleball. Don't get me started on pickleball. Tennis, single tennis, training on the beach, sprinting, sled pulls, anything where you are getting your heart rate up, going back and forth. That's an interval training, right? Let's see. Let me skip this. You're getting to the conclusions here. Pet peeves of the fitness industry. Okay, yeah, I get these questions all the time, so it's worth noting here. Whey protein. People ask me all the time, what whey protein do you drink? Well, yeah, I drink a whey protein, right? I'm highly active. I don't get enough protein throughout the day because I train so much. I'm trying to hit my BMR told me I need to hit 300 grams of protein per day. There's no way I hit that. So yeah, I do take a whey protein. I use Thorne. I just had 50 grams of Thorne whey protein before doing this call because I've not hit it. But for most patients, unless you're training intensely, unless you're not recovering well, you're feeling that muscle soreness, whey protein is probably not necessary. You just need to eat meat. You need to eat more eggs. You need to focus on your nutrient density. Bulking and dirty bulking, I'm not a fat fan of this. It's because when you grow fat cells, and you do grow them, they multiply, right? Muscle cells, they perform hypertrophy for the most part. They just grow bigger. Sometimes elite bodybuilders, I think they can actually make them multiply. You can make muscle fibers multiply, but it's much easier to multiply fat cells. You just need to eat too much and they grow too much. They multiply. They never go away. You can shrink them through caloric reduction and through training, but they're not going to go away. So I'm not a huge fan of the dirty bulking, is because those fat cells will just be waiting for someone to go off their program. It's going to be much easier to gain the fat cells back again, right? This is why people gain weight so much easier again. If you lose the fat, you don't lose it. It just shrinks. The cells get smaller. So not a fan of bulking. Fearing the free weights. It's unfortunately, women are predisposed to this. They worry that if they pick up a dumbbell, that they're suddenly going to look like me. It took me years to achieve this physique. You're not going to look like me. It's not going to happen. I guarantee it's not going to happen. You're not going to get bulky from this. Right? Just don't worry about it. Lift weights. You're going to improve your metabolic adaptation. Don't worry about the whole getting bulky thing. Toning. This is another thing that's a fictional concept. It's targeted fat loss. It's like people tell me, I want to lose fat off my belly, for example. Well, you can lose fat off your liver. That's been proven. You just need to lower your calories and you need to do some exercise. You can readily lose fat off your liver, but you're not going to get a 6-pack. You can't sit up your way to a 6-pack. You're going to grow your muscle definition. If your genetics are 6-pack abs, that's going to happen for you. If you get lean enough, if you train enough, if you grow the muscle, that's going to happen. But for most people, they don't have the genetics for 6-pack abs. So they can't sit up their way to that. That's not going to happen. Smoothies or juicing as a concept for weight loss. It's self-sabotaging. Don't drink your calories. When I look at their diets and it's a morning smoothie, I'm like, why are you doing a banana, strawberries, mango, and maple syrup? Well, it's all organic. It's all healthy. I get it from the co-op. Sorry, you're drinking your calories. You just eat eggs, eat some avocado, eat real food. Don't do the whole juicing thing. It's not worth it. Waist trainers, don't get me started on that. Pre-workout drinks, unfortunately, are filled with caffeine and sugar. There's targeted ways to get the nitric oxide pump, right? There's the Berkeley Life supplement. It's great for the nitric oxide. There's citrulline, arginine, fantastic, right? If you want a caffeine boost, because caffeine does help with performance, it does. There's no getting around it. Drink an espresso, but don't go crazy with the pre-workout drinks. And then the last one is GLP-1s like semaglutide and tirzepatide. They may cause muscle loss. So if you put patients on this, Get DEXA body composition scans, monitor them. You may be shocked what you see. I had this one guy, he got on tirzepatide, did it for 3 months, and he lost 8 pounds. But when we looked at the DEXA, he lost 6 pounds of muscle and 2 pounds of fat. I was like, geez, this is not good stuff. Let's change up the program here. Final thoughts, resistance training is key towards improving metabolic health and decreasing morbidity and mortality across the extended lifespan. Focus on the compound movements. Do progressive resistance training. It means starting slowly and making it harder gradually. Untrained patients need a personal trainer. I tell you what, they will fail. They will not be consistent unless they are with a trainer. I've never seen it happen where someone just is unconditioned and just suddenly starts going to the gym and is making progress. They need a trainer. They need someone who knows what they're doing if they've never had the education in this. Sure, you can look up YouTube videos and stuff, but I just never seen this happen in real life. You need someone who knows what they're doing, who can guide someone. HIIT and cardio should be incorporated to train both energy systems. Nutrient density is more important than calorie in and calories out, but both are to some degree very important. Prolonged fasting, calorie in, calorie out, can negatively affect hormones. That's a topic for another time. Hormones respond to progressive resistance training in young person, but not in the older. So the hormone replacement therapy is something that will help your patients out and will be a great referral base for you. Get to know your personal trainers in the neighborhood. You will be mutually beneficial to one another. Monitor labs when starting any program, plus or minus advanced imaging like abdominal MRIs or DEXA body composition scores. I don't recommend CrossFit or powerlifting just to the risk of injury. And that's all we have here, Dr. Dayton. There may be some questions in the chat. Let me see here. Nario asks, can we get a copy of slides? Yes, I will give you a copy. Let me put that in the chat right now. Hold on. I always share these. Okay. There, it's in the chat. You can copy that. Dr. Donahoe asks, what age for men and women do you start hormone replacement? When it starts going downhill, I'm age 30. I'm already on hormone replacement. I take DHEA and pregnenolone every day, and I take a growth hormone supplementation. I take a bioprotein that helps support growth factor in the body. So yeah, age 30. Oh, I'm on thyroid hormone too, because my thyroid hormone has been no good for some time now. And at the last conference at A4M, we were learning how important optimizing T3 is. Apparently, if you get it to 4, you reduce heart disease. So everyone has low T3 and everyone has heart disease. So that's something to consider. So yeah, I'm on at least 4 different hormone replacements at age 30. And just because I'm being preventative and trying to stay ahead of the curve here, trying to prevent disease, not be reactive to disease. That's the whole point of my practice here at Iron DPC. It's be preventative, right? And Dr. Mario asks, how many days in a week should we do resistance training and how long? Well, it depends what sort of training modality you're using. Like if you're using the X3 system, it's very efficient. Within 15 minutes, you can get a fantastic pump. And it's because the overall volume that's included in the X3 system is tremendous. So you're typically doing between 20 and 30 reps with the X3 system. If you're doing 20 to 30 reps and you're going to failure on that, you've hit that volume that you could have hit if you did a traditional bodybuilder program of like 8 to 12 reps, 3 to 4 sets, right? So if I do 2 or 3 sets of 20 or 30 with the X3 resistance band system, I'm hitting a massive amount of volume. So I won't have to go to the gym 5 days a week. I have to go to the gym maybe 3 days a week because I'm hitting 90 plus reps on this system. Where if you do a bodybuilder split, yeah, bodybuilders there Monday through Friday, probably Saturday, because they're hitting chest on one day, they're hitting back on another day, they're doing delts on another day, they're doing biceps, they're doing triceps, they're doing legs. So yeah, they're going to target different muscle groups on different days of the week. So you can do that. If you do strength training where you're doing super heavy loads, right, you're going to go maybe, once or twice to do super heavy loads, and then you're going to need to take a huge rest day if you're doing max, powerlifting strength training. Maybe do some little bike riding or something to recover, let your central nervous system recover, right? But for me, I hit it pretty much every day of the week because my medical office has a gym, so I have no excuse, and it's right there. I like training. I'm just like that, so I enjoy it. So I'll hit it every day. I'll usually do something every day, and I've adapted to this point where I can train every day, and plus I'm on this growth factor, which helps me recover very quickly. It's kind of like a cheat code, so I can hit it every day, and I recover very fast. So there's a lot of ways to do that. Dr. Mario also asked, if you want to build muscle, should we still do cardio? Yeah, you definitely should. I'm a testament to that. I've somehow managed to maintain a very good physique while playing competitive and professional tennis. I'm probably an outlier in that. Anybody else at these tournaments, like the typical patients I play, or people I play at these tournaments, are scrawny kids. They're like 17 years old. They're like a twig. And they can outlast me on the court. So I don't think my muscle is like conducive to professional tennis, but I'm doing the best I can with like a very good physique while playing professional tennis, which not many people do that. So yes, you can do cardio, and you probably should if you want to lose the belly fat and get a little bit more definition, is incorporating some cardio or HIIT training into your bodybuilding program. Dr. Soriano says, plastic surgeon will say otherwise about losing fat for 15K. Correct. Yeah. So the only way to, after fat cells have multiplied would be probably liposuction. I think I saw some studies on that. I don't know if it modifies disease risk. I think I saw one study where liposuction doesn't modify like heart disease risk. Like, so losing the fat after you've had the liposuction, it doesn't like modify disease. But maybe there's more studies that prove me wrong. I'm sure plastic surgeons would like to have some cardiometabolic benefit to their procedures. Dr. Naria also asks, how do you know that you reached a plateau and need to change your workout? Yeah, that's a good question. Muscle soreness can be an indicator. I know that if I'm finally sore, I'm like, well, I'd really hit it this day. I've kind of hit my, I think my natural peak physique. I don't think I can progress much more unless I, started taking, androgens, which I'm not going to do. So I kind of have figured out where I've plateaued, and I'm kind of okay with it. Hard to tell. I think people can do a lot more than they do. I think the human body is capable of much more. I don't think people push themselves enough. No one goes to failure, right? When I see people training at commercial gyms, no one's going to failure. No one's pushing themselves that extra rep, right? Pushing yourself that extra rep is what's going to cause the muscle to grow. The muscle soreness is good. Pain is different. A joint pain is different. But if the muscle is sore, that's good. I had a patient, he'd never lifted in his life before. I put him out on the X3 band, and I started having him push. And he's only at rep 5. And he's like, it hurts. I'm like, where does it hurt? He's like, it hurts right here. What's this? I'm like, that's your tricep. This is a chest pressing exercise. Yes, it's supposed to hurt. That's good. Keep going. So, yeah. Yeah, Dr. Serena says, yeah, you're right. It doesn't modify risk. Yeah, I didn't think so. Liposuction, I don't think it's a disease modifier. Very good. Any other questions from the chat?
Well, do you know your own omega-6 to 3 inflammatory index?
I do.
Or your
actually,
patients?
I do. I measure that in myself and patients with Vibrant America. Fantastic tests, and I know exactly who's eating the seed oils based off high omega-6 level.
So what is your index?
Mine is actually a subject for Monday lecture, but mine's super high. My omega-6 is very low. My 3 is very high.
Okay, so you're below 3 to 1?
Yo, I can pull that up.
So the omega-3 index by itself needs to be over 10% for an athlete. And all of the athletes I've tested, and I just recently gave a talk about omega-3 and athletes, they're all over 50 to 1. They're burning DHA like there's no tomorrow. And That's what's causing your anaerobic state, and that's what's causing your mitochondria nutrient deficiency that you were talking about. So you need to really analyze your 6-3 index.
Yeah, let's see, my 3 to 11 point. You're right. I want to see where my here it is. What is it?
I mean, it's pretty simple. If your omega-3 is above 10% in your membranes, right, not liquid blood,
Yeah,
then your
RBC.
index is going to be below 3 to 1, your inflammatory index, because the arachidonic acid is going to go down.
My arachidonic acid is so this is RBC I did on myself. 17.6. My AA EPA ratio was a little bit high, 21.5.
Yeah, so it's not below 4 to 1. And that's the reason why you need to spike yourself with hormones. If your index would be below 2 to 1, where it should be, you wouldn't need those.
Ah,
It naturally spikes all your testosterone and growth hormones and your aerobic state. So, but everything else, I mean, fantastic stuff. And I wish I could just swing by and get on your program. Where are you located?
in the Atlantic, Florida.
Oh boy, I was just there. Yeah, too far. I'm in the opposite end of the country. So,
Is that right? I hear a
yeah.
German accent. You're German,
Yeah, I'm German. Yeah.
but you're here in Florida?
I was at the conference. Yeah, it was fun. Yeah.
Oh, the A4.
Yeah, well, maybe I'll stop by the next time I come to the conference. So.
Yeah, you'll like it. We have a great facility.
Awesome. Good job.
Let's see. Any other comments? All set. Okay. Very good. Thanks for attending, everyone.
Thank you so much. This was extremely informative. I really love this myself.
Fantastic.
Thank you very much, doctor. It was a pleasure. Thanks so much.
Of course. Bye. See you next time.
Have a great night, everybody.
Bye.